Hi, this is Piyush Bhargava and you're watching the Renal Scan teaching file. Let's start with reviewing the renal scan protocol. The common indications for doing a MAG3 renal scan include evaluating renal perfusion, differential function left versus right kidney, evaluating patients for obstruction. This is the situation where we inject them with Lasix and calculate half time of emptying, evaluate patients who have renal transplants, and to evaluate patients who are suspected of having renal artery stenosis. These scans are done using captopril. The radiopharmaceutical is 10 millicuries of technetium-99 and mag3 injected IV. Immediately after injection of the tracer, we acquire dynamic flow images of the abdomen and pelvis in a posterior projection 1 to 2 seconds per frame for 30 to 60 frames. Then we acquire images 1 minute per frame for next 30 minutes. Sometimes Lasix is inbuilt in the protocol and is administered by the technologist during the scan. At other institutions, the initial acquisition is reviewed and then a decision is made whether Lasix is needed or not. The mechanism of uptake of technetium-99 and mag3 is tubular secretion. Physiologic distribution is seen in the kidneys and excretion into the ureters, urinary bladder. There is vicarious excretion of the pharmaceutical from the liver, and we can see gallbladder activity as physiologic uptake as well. The critical organ is the urinary bladder. Case number 1 shows a dynamic acquisition from a normal renal scan. There is prompt symmetric uptake in both kidneys. There is prompt excretion of the tracer from both kidneys into the collecting system, ureters, and the urinary bladder. At the end of the study, there is very faint, if any, soft tissue activity remaining. There is a very faint renal activity remaining. Most of the tracer has been excreted from the kidneys into the urinary bladder. These are the characteristics of a normal MAG3 renal scan. These are the initial blood flow images. You can see the activity coming down into the aorta and the iliacs. At the same time, we see activity in both kidneys in a symmetric fashion, so there is good blood flow to both kidneys. These are 1 to 2 second per frame images. Next, we have the nephrogram images, where these images are in posterior projection. So here's the left kidney, here's the right kidney. The urinary bladder should be in the field of view. As we go through the images, we find that the cortical transit time, the amount of time it takes for the kidneys to excrete urine into the collecting system, is within 5 minutes. The function in both kidneys is symmetric, and over a period of time they both excrete the tracer into the urinary bladder. There is no evidence of stasis in the kidneys, collecting system, or urinary or the ureters to suggest any evidence of obstruction. Case number 2, multiple images from a renal scan in a patient who presents with renal colic. Let's start with reviewing the dynamic acquisition. Here, let's start by looking at the left kidney. It takes up the tracer promptly, excretes it into the collecting system and ureter and the urinary bladder. But look at what's happening to the right kidney. Right kidney takes up the tracer, excretes the tracer into the collecting system, but then it stays in the collecting system and there is no transit of tracer seen from the collecting system into the ureters. The UPJ seems to be the site of obstruction. So stasis at this point is concerning for obstruction, and this should be followed up by Lasix to see if this activity washes out. Let's look at the flow images. These flow images show symmetric blood flow to both kidneys, so the blood flow is not compromised. The appearance of obstruction on a renal scan depends on the chronicity of obstruction. If the obstruction is acute, we can see a renal scan like this, where the flow is preserved, the function is preserved, but there is stasis which does not respond to Lasix. So let's look at the nephrogram images here. You see progressive accumulation into the collecting system, and here in the bottom right we have an image where the technologists have drawn the region of interest around the left and the right kidney and background for individual kidneys, and we see the time activity curves. So the time activity curve, which is blue here for the left kidney, goes up and promptly goes down. This is normal. The time activity curve for the right kidney goes up and continues to stay up. Remember, to make sure that the time activity curve or the region of interest here includes the entire kidney, including this area of stasis. Sometimes the technologists mistakenly draw just the cortex, which is incorrect. Sometimes they do not include the entire renal collecting system, or the ureter if there is any stasis in the ureter. When we are evaluating response to Lasix, we want to see the response to Lasix to the entire area of obstruction or stasis. So make sure that the region of interest is drawn correctly. Here, the time activity curve stays up for the right kidney, and you can see a vertical line here, the blue line. At 20 minutes, the protocol involves injecting Lasix. So the Lasix was already injected somewhere here at the time of 20 minutes, and in response to Lasix, the curve does not come down. So when the half time of emptying in response to Lasix is more than 20 minutes, which is seen right here, diuretic T half, which the computer calculates. When it is more than 20 minutes, we make a diagnosis of high-grade obstruction. So overall, in this case, the findings are consistent with the right-sided UPG obstruction. Case number 3, another patient with history of obstruction. Let's look at the flow images. There is prompt blood flow to the left kidney, but there seems to be slightly delayed blood flow to the right kidney when compared to the left kidney. When we look at the function is prompt. The left kidney excretes the tracer promptly into the bladder. They should have moved the camera a little bit more inferiorly, as the urinary bladder is not in the field of view. At the end of these images, we find that the left kidney has emptied completely. The right kidney shows stasis, just like the previous case where we saw right-sided UPG obstruction. So here again, we want to give Lasix and see how this empties. In response to Lasix, there is some emptying, but not significant over a period of time. So this again would be consistent with right-sided UPG obstruction. Another patient where the blood flow is slightly compromised on the left compared to the right. In terms of renal function, the kidney takes up the tracer, but in a very patchy fashion compared to the right kidney, and not as much tracer uptake is seen in the left compared to the right. It produces some radioactive urine, but there is no collecting system activity. At the end, we find that the right kidney has emptied normally into the bladder, but the left kidney does not show any excretion of the tracer. As I was telling you before, the appearance of obstruction on a renal scan depends on the chronicity. So the earlier two cases we saw where there was UPJ obstruction, the flow and function was preserved, but there was stasis which did not respond to Lasix. But here, the obstruction is a little bit more chronic or long-standing, because of which, secondary to the back pressure of all the urine in the collecting system, the function and the blood flow are compromised too. Here, in response to Lasix, it concentrates the tracer, but there is again no excretion. So here we are looking at findings consistent with slightly more chronic left-sided UPG obstruction. Let's look at case number 5. Blood flow images showing normal flow to the right kidney. No flow is seen in the left kidney. It almost seems like they've had a nephrectomy. These are 1 minute per frame images. The right kidney shows normal excretion into the collecting system, ureter, and the urinary bladder. But there is very faint, if any, suggestion of the left kidney. And so this would be even more chronic appearance of obstruction, where the function is compromised, the blood flow is compromised, and there is hardly any tracer going into the left kidney. And it may appear as if the kidney is not present, but the ultrasound scan or a CT can confirm that the kidney is there. It's chronically hydronephrotic, and the anatomic finding that you would find in this situation, that the cortex would be very thin. And this is what we call a chronically obstructed kidney. Case number 6, here we are trying to evaluate a renal transplant in the left hemipelvis. Remember, when we do a renal scan with MAG3 to evaluate renal transplant, these images are acquired in an anterior projection. So Looking at the blood flow to the transplanted kidney in the left hemipelvis, the blood flow is good. When the activity comes down into the aorta and the iliacs, at the same time we see prompt uptake in the transplanted kidney in the left hemipelvis. As we go through the images, we find that the kidney produces radioactive urine which accumulates in the urinary bladder. But at the end of the study, we find that there is significant amount of activity in the soft tissues, there is significant activity in the transplanted kidney, and there is some production of radioactive urine. The post-void spot view is shown here with similar findings, but there is another reniform focus in the right hemipelvis. This is a previously transplanted and failed kidney in the right hemipelvis. So the findings of good blood flow and compromised function are consistent with either acute tubular necrosis or cyclosporin toxicity. The way to differentiate between the two is when was the transplant performed. ATN is more acute and it happens after transplant. Cyclosporin toxicity is more chronic when the patients have been on cyclosporin for some time, and the imaging appearance is the same: good blood flow and compromised function. For any kind of rejection, remember that the blood flow needs to be compromised. So as long as you see normal blood flow, there is no evidence of rejection. Another case with similar findings, we are evaluating a transplanted kidney in the right hemipelvis which shows normal flow, and look at the function. It takes up the tracer and then the tracer washes out of the kidney. There is some activity here in the pelvis, but look at that activity. It's seen on the first image as well. So this isn't urinary bladder activity, this is penile blush activity. So the kidney takes up the tracer and then the tracer washes out back into the soft tissues, and there is no production of radioactive urine. So again, good blood flow, compromised function, ATN versus cyclosporin toxicity. Case number 8. This is an interesting case with an artifact. The images have been shown deliberately in higher intensity. Both kidneys take up the tracer, excrete the tracer into the urinary bladder, which becomes larger and more intense with time. But the interesting finding is here in the superlateral aspect of the right kidney, where a focus appears and becomes more intense with time. This focus was further evaluated by a posterior view, which is seen here, slightly more delayed image, and then a right lateral view where we see that the focus is linear and in the appearance of gallbladder. So this is vicarious excretion of technetium-99 and mag3 from the liver into the gallbladder. So this is normal and physiologic. Case number 10, a 42-year-old male with history of liposarcoma on chemotherapy who presented with renal insufficiency, urea of 58, creatinine of 8.0. Ultrasound showed a normal left kidney and a compressed and hydronephrotic right kidney. So we are looking at a renal scan which shows uptake of tracer in the left kidney, and maybe there is some faint indication of some activity in the right kidney, but I'm not sure. At the end, we find that there is some excretion from the left kidney into the urinary bladder, but most of the activity is still in the soft tissues. There is abnormal cortical retention in the left kidney, and there is no activity seen in the right kidney. Let's look at anatomic imaging on this patient. So the representative CT image shows that there is a large retroperitoneal tumor. This is their liposarcoma. It's pushing the right kidney against the liver. The right kidney is right here, compressed and small. That's the reason we didn't see any activity in the right kidney on the renal scan. Here is the ultrasound from when the tumor was biopsied. This is the tumor. Here is the needle going into the tumor, and here is the small compressed right kidney. So when there is no activity seen, then we want to evaluate the region anatomically using an ultrasound or a CT to see what is the status of that kidney. Another example of similar finding, a 7-year-old female with worsening renal function. Left kidney shows normal uptake and excretion into the urinary bladder. There is no activity seen in the region of the right kidney. On the delayed images, maybe there is some faint suggestion of right renal activity. Here is the ultrasound image on this patient. The left kidney, which we saw here as normal, is seen here as normal appearance on ultrasound. The right kidney shows these multiple cystic areas which are not communicating with the collecting system. And this appearance is consistent with multicystic dysplastic kidney. And the appearance on the renal scan is characteristic of MAG3 findings in a patient who has multicystic dysplastic kidney. So these are some of the common patterns that you will see on a MAG3 renal scan. Thanks for watching.